Distinguished guests, honorable speakers, ladies and gentlemen, good morning. It is very nice to see all of you once again. I'm pleased to welcome you on the second plenary session about understanding and addressing demographic, epidemiological, and societal changes in cities. The session will be chaired by Dr. Yonette Thomas, Executive Director of the International Society for Urban Health. Please give a warm welcome to Dr. Thomas. I'm honored to welcome our distinguished panelists, Dr. Alex Ezeh, Executive Director of the African Population and Health Research Center in Kenya. Please give a warm welcome to Dr. Alex Ezeh. Next, Dr. John Bird, Director of the Department of Aging and Life Course in the World Health Organization. Please give a warm welcome to Dr. John Bird. Next, we have Dr. Srinath Reddy, President of the Public Health Foundation of India. Please give a warm welcome to Dr. Srinath Reddy. And finally, Professor Richard Wilkinson, co-founder of the Equality Trust, Professor Emeritus of Social Epidemiology at University of Nottingham Medical School in United Kingdom. Please give a warm welcome to Professor Richard Wilkinson. Dr. Thomas, I'm giving over to chair the session. Thank you.
Okay, thank you. Welcome all, and as our colleagues said, we do have a distinguished panel here this morning to really share with us their thinking on this whole notion that epidemiologic shifts and patterns, along with demographic transitions, migration patterns, etc., present opportunities, great opportunities, and significant challenges for the health maintenance of people living in urban communities and cities. Our distinguished panel will highlight for us how policies and programs are impacted and adapt to achieve the highest level of health for people in these environments. So without further ado, I ask Dr. Ezeh to begin our comments.
Okay. Thank you.
Either place. Yeah.
Okay. Thank you, and good morning. I'm really delighted to be here and to present a disciplinary session. I came in yesterday evening and somehow my luggage decided to take a vacation in Amsterdam. But so up till now, I still don't have it. And for those who try to hug me, well, don't mind the fact that I'm wearing the same clothes for the last almost 3 days. But I think I come from the African Population and Health Research Center in Nairobi, and we've had a very good relationship with the International Conference on Urban Health, and we hosted the 2009 conference. I think I'm there until the end of the year, but I stepped down this Friday as the executive director. And I have every confidence the center will continue to engage with the ICUH conference. And I will continue to do some of the work that I've really been particularly interested around slum health. The topic we have this morning, demographic, epidemiological, and societal changes, or trends, it's quite broad, and we can spend the entire conference just discussing any one of these trends and the way they impact life and well-being generally. And they are important in themselves, but beyond that, their importance within the urban context is really something that is quite unique and needs to be fully understood and addressed. So I would like to look first at demographic trends. I think when we think about demographic trends, one of the important things to look at is the numbers. It took the world about 1,800 years to reach its first billion. Another 123 years to reach the second billion. And in just 33 years, by 1960, we reached 3 billion. The Great Acceleration started around 1950. And between 1950 and today, we've tripled the world population in about 67 years. And it is projected that this population will add another 2.2 billion over the next 33 years and reaching 11.2 billion by the end of the century. One of the things you will notice with this rapid growth and continuing growth of the population is that high-income countries are contributing less and less to this growth. Indeed, by 1950, they accounted for about 26% of the global population. This has continued to decline to about 15.8% this year, and this trajectory will continue, reaching about 11% of the global population by 2100. On the contrary, sub-Saharan Africa shows the complete opposite of what we see in the high-income countries. In 1950, sub-Saharan Africa accounted for just 7% of the world population. Today, in 2017, it has reached almost 14%. And it is projected by the end of this century, 40% of the world population will live in Africa, and 90% of them will be in sub-Saharan Africa. You know, between 1950 and 2100, the global population will increase by about 1.4 billion people. But sub-Saharan Africa alone will increase by 1.8 billion. I mean, some of these numbers may not mean anything to many of us, but the reason why sub-Saharan African population will increase, the increase will be larger than the increase in the global population, is the fact that the population in many other parts of the world will be declining over that period. When you think of the world in 2100 with 4 billion sub-Saharan Africans or 4.5 billion Africans, I'm not sure what comes to your mind first. Apart from the spatial distribution by geographies, the other important part of this change is the change in the distribution of this population by urban-rural residents. In mid-2009, for the first time in history, more than half of the world population lived in urban areas. This trend is destined to continue. And increasingly, all the growth that will happen in urban areas. Indeed, between 2050 and 2100, the urban population will account for about 105% of the total increase in global population. By about 2025, rural population will stabilize and start to decline, but the urban population will continue to grow. And this growth is also not just in high-income countries, but we also see the same in sub-Saharan Africa as well. So, as you look at these numbers, one of the key points that really stands out is the fact that we may not care about urban health specifically if indeed the situation in the last row of there with respect to slum dwellers is not there. Globally, about 880 million people, nearly 1 billion people in the developing world live in slums. Even though the percentages has declined, the absolute numbers have continued to grow. As you look at the case of sub-Saharan Africa, from about 70% in 1990 to 55% in 2014, the latest data we have from UN Habitat, that's a huge decline, and we celebrate that. But over the same period, the absolute number of people living in slum areas in urban areas of sub-Saharan Africa more than doubled from about 93 million people to over 200 million people. And this is particularly important because the profile and the health and socioeconomic determinants and drivers of health outcomes within this population of slum dwellers can be significantly different from what we see from urban averages. I would like this picture of the demographic trends to remain with us as we go through a number of the other issues that we want to look at. So, the basic reason why we differentiate urban areas and rural areas is that their profiles are different, and the drivers of health outcomes may be different between these two contexts. What if we actually know that the difference between slums and non-slum areas in our urban averages are much larger than the differences between rural areas and urban areas? Does it really make sense to continue to define urban indicators using the same way we've done over the years? If you look at this figure, and particularly look at rural and urban in the middle, you see significant differences about infant mortality rates and under 5 mortality rates. This is from Kenya. And you can see a huge difference from 61 infant mortality rate in urban to 79 in rural, and under 5 mortality from 93 to 117. But compare this to the slums. Under 5 mortality is at 151, much larger than even the rural areas, but also much larger than what you get as your urban averages. So the question is, if these differences exist between slums and non-slum areas, and if they are much larger than the difference between urban and rural, what does it mean when we have indicators for urban and we do not know what proportion of the slum population contributes to that indicator, and how has the proportion living in slums been changing and their health outcomes changing? I think this is at the core of what we need to deal with in terms of our demographic and epidemiological transitions. Recently, in a series in The Lancet, we underscored the point that slum health is different from urban health and from our studies on health and poverty. There are unique contextual and neighborhood effects that drive health outcomes in slum areas that we need to carefully pay attention to. And these indicators actually drive and influence a lot of the way we need to design programs and policies to address health outcomes in slum areas. I would like to underscore 3 points around epidemiological transitions, particularly within the context of slums. First is that slums are not immune to other epidemiological trends that occur in the larger population in any context at all. If anything, slum conditions can exacerbate these trends. The second point is that slum areas may have unique epidemiological trends that could remain largely invisible in the larger aggregations of urban averages. And I will use data from the Nairobi Urban Health and Demographic Surveillance System that we've been implementing since 2003 to draw inferences on some of these dynamics that exist within these areas. Finally, it is important to understand, and I think Yonette mentioned this earlier, that urban areas and slums do offer unique opportunities for health and social services that could reach a larger proportion of the residents, and we could achieve this cost effectively, particularly if we look at per capita costs of the investments. From the data I mentioned earlier, you can look at 3 main disease injuries. We collect data on verbal autopsies for all the deaths that happened in these 2 communities in Nairobi. And there is over 6,000 deaths represented in this slide. You can see between 2003, communicable diseases accounted for about 71% of the deaths, and that has dropped to about 50%, and some years it's been around 40%. But over the same period, injury deaths in green accounted for about 11% of the deaths, and that has gone up considerably, reaching about 30% by 2016, and in some years actually reaching almost 40%. The same for non-communicable diseases. We've seen it going from about 6% in 2003 to about 20% currently. Of course, this hides a lot of the differences between subgroups. And I just want to illustrate again what we see in this type of data, where you have this opportunity to really monitor what is going on within these types of contexts. This is looking at the cause of death again over that entire period. And one of the things you see for all age groups and all for men and for women, that the number 1 cause of death is TB. And that accounts for about 18% of the deaths. And it does not vary between the two, between men and women. They are all is about 18% for each of them. You look again, the next second leading cause of death is injuries. Injuries accounted for about 15% of all the deaths. For men, it's actually the leading cause of death for all men, 0 to the last age at 22%. And the burden for men is almost 4 times that of women. The reverse is true for HIV, which is about 18% and 11% for men and 18% for women, but 14% overall. There is no difference with respect to respiratory tract infections, and we'll come back to this again. And the largest difference you will also see is between other causes, where maternal health outcomes becomes important. If you look at this same data for children under 5 years of age, what you see is the predominance of respiratory tract infections, which accounts for more than 1 in 3 deaths of children under 5, and it does not vary between boys and girls. The second is HIV/AIDS, meningitis in green, infectious diseases, and diarrheal diseases. These 4 conditions will account for about 70% of all the deaths of children under 5. You look at adults 15 years and older, the statistics becomes even more troubling, with tuberculosis, again, not changing by gender, and leading cause overall, followed by injuries. But for men, almost 1 in 3 deaths of adult men 15 years and older die as a result of injuries. And HIV, the burden among women almost double that of men, and CVD, cardiovascular diseases, almost double also, again more than double for women compared to men, as the 4th leading cause of death. Again, all of these account for about 70% of the deaths in this population. Why are these things important and these numbers? So, before I get to that, you've seen the role respiratory tract infections cause within this population, particularly for children, accounting for 36% of the deaths. One of our colleagues who recently finished her PhD last month from Umeo University did her PhD, her thesis, on indoor air pollution in the slums. And these are the 2 slums we work in, Korogocha and Viwandani. And of course, the 24-hour WHO recommendation is about 25 grams per cubic meter of space. Here in the slums, it will go from about 73 in Korogocho to 124, depending on the time of the day. And particularly at night, when households rely on kerosene and charcoal for cooking and kerosene for lighting, you can see huge levels. In some of the readings, it's actually the highest they got was about 12,000 micrograms. And these are huge, important issues around the drivers of health and epidemiological transitions within these settings. So, how do we address these issues? I've not talked on societal changes, but I do hope that my colleagues that will speak after will draw on this, particularly the changing family norms and technology and how these things are driving changes, both in the way we live and the way we relate to each other, especially in the urban context. But I want to start to talk about how we begin to address some of these challenges that I've highlighted. And my first point here really is the phrase, and I really like this very much, that demography is not destiny. The fact that we have sub-Saharan African population projected to 4 billion by 2100 does not mean that it should or it must happen. It is a projection. However, when we hide under the cloak of religion and culture, and for political expediency, refuse to abolish child marriages, deny girls access to quality education, and when we get women pregnant, we refuse them access to family planning in the first instance, and we refuse them access to safe abortion services. These demographic profiles that we've painted is almost inevitable in many ways. I do not believe that Africa can continue to hide under these excuses. If I look at Italy, it is 96% Catholic. Contraceptive use is about 67%, and TFR is about 1.34 children per woman. I look at Iran, it's an Islamic state. Contraceptive prevalence is about 77%, and TFR is about 1.6. So, it is not religion, and it is not culture. We've seen Rwanda in the last 20 plus years has reduced their total fertility rate from about 8 children per woman to about 3.8 children per woman currently. So it can happen. We've seen in the Matlab region in Bangladesh, poor women, uneducated, where services exist, are able to use family planning services and achieve very low fertility levels. These are low-hanging fruits that can easily be achieved. So, the current discourses we have and the sentiments in DC and other places, I think, do not help matters. And we need to, we've tried to address these issues in a forthcoming piece in Science that will come up in the next 2 weeks. And I'm hoping that it's something we will pay greater attention to. The second point is the need for us to make slums more visible in national and global reports. The continued invisibility of the 1 billion people that live in slums in the developing world in such national and global reports, I think needs to stop. This November, with colleagues at the University of Warwick, we'll be organizing a major meeting. We'll be organizing a major meeting in Bellagio, where we're bringing national governments and UN agencies and development partners and researchers and civil society organizations to look at how to change this. And I think it's a very simple thing that could be done. If we can include in our mapping during censuses an identifier for each cluster, whether they are slums or not, then it means when we draw our national samples, we can actually be able to identify slum clusters, and develop our national master sampling frames, including that domain. And when we do national surveys, we can actually sample within the 3 domains of slum, non-slum, urban, and rural. And we can begin to understand the drivers of health outcomes within the slum context, and then see how best we can deal and address these issues. The third point I want to make is really around the issue that we should consider whether we cannot have global standards for clean energy. When you reflect on acute respiratory infections accounting for more than 1 in 3 deaths of children under 5, and you look at the current move within high-income countries to phase out fossil fuel-powered cars, you ask the question, where are those cars ending up? Of course, in Africa. But more than that is the fact that Nigeria, for example, will export the most clean crude oil with the least amount of sulfur, but will import diesel that has the highest amount of sulfur labeled African standards, which cannot be sold anywhere else. With that, what happens? I refer you to the recent Lancet Commission on Planetary Health to understand that planetary health issues is a shared concern for all humanity. And it doesn't matter where these challenges are occurring, they are affecting our common heritage. So, I can say a whole lot more here, but I think I have limited time, and I just want to add with the last 2 points. I looked at the program we have over these next 3-4 days, from yesterday through Friday. And with all the many different programs, there is only one session on injuries, and another one poster session. That means a total of 5 presentations across this entire conference on urban health, focusing on injuries. But injuries account for more than 1 in 3 deaths of adult men in the slums of Nairobi. And where we have the data, it shows that this concern is similar in many other countries and many other areas. So, how do we deal with urban health issues without recognizing one of the key drivers of health outcomes within this context? Finally, if we have to address these demographic and epidemiological and societal trends, we need to recognize the complexities of the drivers of poor health outcomes in urban areas, and the fact that many of these drivers lie beyond the borders of our health systems, our health sectors. They are within security systems, within roads, within transportation systems, energy, and different other areas. And those complexities will be the key drivers of health outcomes in our cities. Thank you.
Thank you, Alex, for those poignant ideas. As we transition, I'll take the chair's prerogative and ask you a question so that the audience wouldn't have a long pause. I want you to be thinking, to share with us, the INUH DSS data are striking. How have you used these data in your research to help inform health programming and policies in Kenya? So I see we're already up for our next presentation, so that's a question I would like you to answer as we go into the next question. So please be thinking of that. We would like to hear. So our next presenter is Dr. John Beard, and John will tell us from the WHO perspective how these demographic trends and epidemiologic shifts impact health of people living in urban environments.
Thanks, Yonette. Yes, I'm going to talk about a different demographic shift, the demographic shift to older populations. And if any of you have ever been to a conference or a session on aging, you'll know that almost every presentation starts with many, many slides telling you what is essentially a very simple story. Populations around the world are rapidly getting older. That shift started in high-income countries, but now it's low and middle-income countries where the fastest demographic shift is occurring. And that means that places like Vietnam, China, Iran, Mauritius, Chile will all soon have similar population structures to that of Japan today. So this is it's a massive shift. It has multiple implications, and no country is excluded, although some obviously aren't moving as fast as others. Now, when you go to those conferences, or the reason I'm not going to take that approach, is that sort of leads to a quite problematic discourse. If I can get this. Okay, that leads to a quite problematic discourse. Because one of the understandings when you talk about these older populations is that there is such a thing as an older person, a typical older person. All older people are the same. And so, for example, this figure, which comes from our World Report on Aging and Health, shows the proportion of people over the age of 60 around the world by different countries by the middle of the century. What that shading shows and leads you to think is that everybody over 60 is the same. And yet we know that nothing could be further from the truth. In fact, one of the hallmarks of population ageing is incredible diversity. This is a figure from the Australian longitudinal study on women's health. And what we're looking at here is physical capacity across the life course. And these are the bounds of physical capacity in that study. There were 3 separate sub-cohorts followed longitudinally. And what you see is how broadly the bounds extend as you get to older age. And what that means is that even in the poorest country in the world, even in some of the slums that Alex is talking about, there will be 80-year-olds who retain the robust health of a 20-year-old. But there will also be some 60-year-olds who require significant care and support. And one of the problems if we start talking about a typical older person and where those demographic discussions often lead is that we actually try to draft a generic policy response shaped around this idea that we have of a typical older person. And that typical person may be the robust one, and we think, well, let's try and get them into the workforce. Or it may be the frail one, and we think, well, there's a tsunami of older people coming and we can't afford it and we have to cut costs. What we need to do if we're going to shape a very effective population health response is to cater for the whole of that diversity, all of that population. So that's the first message I want you to remember from my presentation. The second one is that this distribution, this diversity, does not occur by chance. So when we looked at income adequacy across the life course within this cohort, what you can see is that we found that the people who experience the best trajectories of health, the people at the top who in older age experience that robust health, are much more likely to have experienced the cumulative impacts of advantage across their lives, while the people at the bottom are much more likely to have experienced the cumulative impact of disadvantage. That's got multiple implications because it means that the people at the bottom in older age are often those with the least access to the resources they need to meet their needs. And we need to be shaping our policy response not around a typical person, but thinking about how we can capture this whole diversity, how we can make our response relevant to everyone, but how in particular we can focus on those at the bottom and lift them up. Now, if we're going to do that, we have to think about health, because as you can see, that diversity is very driven by your health status. And in 2015, WHO released the World Report on Aging and Health. It's been quite influential. It's been downloaded over 150,000 times. So if you haven't looked at it, I urge you to also have a look at it. It's a good read. And what we did in that report was try to explore what health means from a life course perspective. And what we tried to move away from was the idea that good health is just the absence of disease. And instead we framed health around the idea of functioning. And so this was our definition of healthy aging, the process of developing and maintaining the functional ability that enables well-being in older age. Now that may sound like a little bit of a motherhood statement, but we're actually very concrete about the terms we used and the ideas we explored in the report. And I'll try and take you through that and then specifically look at the relevance for cities. So what is this functional ability? It is my ability to be and to do the things that I've got reason to value. And if you ask older people what that means, the first thing is older people want their basic needs met. And this is one of the issues that Alex is talking about in Slums. How do we meet basic needs for housing, for food, for safety? But this is an issue not just in slums, it's an issue even in rich cities. So we need to be thinking, and I think it's a particular issue that municipalities often have responsibility for. The next thing that older people say is right until their last breath, they want to have the opportunity to learn, grow, and make decisions for themselves. And often that opportunity is not given to them. But we can do that. We can do it by providing lifelong opportunities for education. We can do it by treating people with dignity and allowing people, even though they may be experiencing severe losses of capacity, to make decisions about their own lives. The next thing they want, and this again is something I think has a very urban twist to it, is they want to be able to get where they want to go. They want to be mobile. They also want to build and maintain relationships. And older people around the world want to be able to contribute. And even in Africa, when we went and interviewed older people in Africa, this is something they said very strongly. They want to make a difference, particularly for their families. They want to see the next generation have the opportunity to live a better life than they have. Oh. Okay, so if we think about dysfunctional ability, it's made up of two components. One is the individual that you see before you, and we call this their intrinsic capacity, so all their physical and mental capacities that enable them to do the things they want to do. But these days, for me to read, I need glasses. To sit down, I need a chair. To get where I want to go, I need some form of transport. So my functional ability isn't just about me. It's also about the environment in which I live. What you see across the second half of life is that intrinsic capacity tends to decline. We tend to lose physical function. Our cognitive function changes, and we experience other physical and mental changes internally. But the environment can actually help us maintain a level of functional ability. And if you look at this curve with the eye of faith, you may be able to see that there's probably three parts of the curve. And if you look at any population in the second half of life, they will likely fall into one of these three groups. A group with high and stable capacity, a group with declining capacity, and a group who've experienced a significant loss of capacity. So this is trying to tease out that diversity I spoke about at the beginning. This is how you might think about that diversity. And this is how you might start to shape a policy response. Now, if I think of the role of cities have a role in helping people build and maintain capacity, but they also have a role in ensuring functional ability. Let me give you some examples for each of these different stages. For people in high and stable capacity, the most important thing here is to prevent disease. So this is a whole NCD agenda, how we can help people to remain physically active, to eat healthy food, not to smoke, and so on. And clearly, this is an urban agenda that we need to be addressing. For people with declining capacity, what we should be focusing on continues to be prevention, but not the prevention of disease. It's the prevention and slowing of these declines. And from a health systems perspective, what that requires is services which don't just respond to every condition that an older person presents with. We require integrated services that span multiple conditions, because most older people actually experience multi-morbidities, and treat them in an integrated and coordinated way. And when intrinsic capacity has declined to a very significant degree, this is where long-term care becomes important, so that people can still continue to live lives of meaning and dignity through the support and care of others. Now, if you think about the gap between intrinsic capacity and functional ability, and you think about what you can do in an urban environment to help people achieve the highest possible ability regardless of their level of capacity, you can think for this first group who are experiencing high and stable capacity, this is often how do we break down barriers. This is how do we remove mandatory retirement age? How do we overcome ageist attitudes in the community that tend to marginalise older people or exclude them? For people where the capacity is starting to decline, however, the city creates many other opportunities. And our opportunities to help older people compensate for those losses. So if I want to get somewhere, if there's disabled access transport and then disabled access building where I want to go, it becomes much easier, even if I've experienced a certain level of physical limitation. And then for these people with significant losses, this is again where long-term care becomes important. And in many countries, it's at an urban level that the responsibility for long-term care falls. And so again, I think cities need to be thinking about how they can reinforce functional ability regardless of people's status. So that framework of thinking then led last year at WHO to the adoption by our member states of the Global Strategy and Action Plan on Ageing and Health. And it had 5 strategic objectives. The first one is a commitment to action, and embedded in that was a campaign to combat ageism and to change the way people think about ageing and older people. The second, and the one that's probably most relevant to the meeting, is the creation of age-friendly environments and ensuring that everybody has the opportunity to grow old in an age-friendly environment. The third is better designing and aligning our health system to the needs of older people. The fourth is developing systems of long-term care, and here we weren't talking about institutions, we were talking much more about how you can support people in their home and in their community to continue to live lives of dignity and meaning. And finally, better measurement and monitoring of all of these things. I think all of these things should be part of the urban agenda. In terms of the age-friendly environments theme, many of you may have heard of our global network of age-friendly cities. We have now expanded to be the global network of age-friendly cities and communities. The goal of the network is to bring cities together from around the world to share their experiences and also to encourage them and provide the information that can help them come up with some innovative strategies for action. And it's been incredibly successful. We launched it about 5 years ago with Michael Bloomberg in New York, and it now has over 500 members, including New York, Paris, Tehran, Seoul, major cities around the world. What it's lacking, and what I'd like to talk with Alex about, is how we can actually move this into the south, and how can we can think about the issue of an age-friendly slum. I mean, what is that? Because I'm sure it's possible to make a slum more age-friendly than it currently is. When we launched the network, we released some guidelines on how to think about being age-friendly, and we came up with these 8 domains. The problem with these domains proved that they were a bit of a cookie-cutter approach, and that it worked well for some cities. They would tick off each of those boxes, but really if you're going to be effective, you need to span a whole lot of municipal responsibilities, and thinking about these domains sometimes doesn't work, and which is why we're now shifting more to that tree I showed you earlier on about functional ability, and thinking about a city can help people do those things that are important to them. So for example, let me give you an idea of, here's an older person who would like to go shopping in point B. To do that, it doesn't require one simple action. It actually requires a whole matrix of interventions that can make that easier. So for example, is their house accessible? And in many cases it's not, particularly in urban areas where we have high-rise, which may or may not have elevators. Are there accessible buses and taxis? Are there assistive technologies available to help to assist them navigate some of the obstructions that they will face? Is the neighbourhood safe and pleasing? And we know there's very good evidence that older people are much more likely to get out in the neighbourhood if they see other older people doing it and they get the sense that it's a safe place. Are the footpaths and pedestrian crossings appropriate? The crossing speeds at intersections, are these slow enough to allow an older person to get across? Are there park benches or places where people can rest? Are there toilets? These are always brought up by older people as a limitation in why they may or may not get out into their urban environment. How friendly and helpful is the shopkeeper? And finally, which we shouldn't forget, are there health services available to help them maintain their capacity, and are there long-term care services if we need them? So if we're going to enable this person to get from A to B, we need to be thinking about all these different components. In terms of the global network, it's been very successful. We're taking some steps forward to make it even more successful. In many countries, we have affiliated networks. So, for example, in the United States, the American AARP has taken on the role of supporting the network across the United States, and it now includes almost all the major cities in the US. We want to strengthen them, and we want to link them and the cities themselves to other key partners, particularly potential funders or particularly the private sector, but also researchers. Because at the moment we often have policymakers going their own way. We have researchers coming up with the evidence that might be relevant, but often the bridge between the two doesn't exist. To do that, we have an electronic platform at the moment called Age Friendly World, agefriendlyworld.org. If you want to access it, we want to upgrade that and make it more interactive. And we also want to build capacity in cities around the world so they can understand these issues and so they can start to put in place the actions that are required. Now, in terms of this meeting, what should you be taking home and thinking about? As I said earlier, our global network at the moment is very much focused on the north. But this is not something that is not relevant to the south. And I'm sure there are some innovative new ways of doing things which we could be considering. One of those, I think, is blurring the boundary between municipal, community, health service, and trying to think of a much more organic way of bringing all those resources together. One terrific initiative that does that in many parts of Southeast Asia and Africa are things called intergenerational self-help groups, or older people's self-help groups. Often coordinated by a group called Help Age International. I recently visited one in Vietnam. They tend to provide a pool of resources that they can draw on. They provide some training to that group, and then that group itself becomes a resource for the community and older people who may require care and support. It may link through to the health system. And so, for example, in the one I visited, they actually managed to get $5,000 of seed money from a local private industry. They then used that for funding microcredits or for supporting caregivers. They've managed to retain and increase the pot over the years. And so this is a really sustainable and ongoing initiative that I think could form the basis for some really effective action. And it's also something that we could be doing even in New York or in Paris, if we were thinking a little bit outside the square. The second thing is there's a lot of things happening out there at a municipal level in relation to ageing. The evidence base is really thin. We need much better evidence because governments are starting to spend a lot of money. And we really need to know whether they are wise investments or would they be better spent in other places. And so I think, I would imagine that many of you are working on issues like walkability and things like that, really strengthening the evidence about what works, what doesn't work, particularly in terms of what interventions are demonstrated to be effective would be very useful. As I said earlier, I think we somehow need to build this bridge between research and policy development. And that's not just about communicating what you do better. It's actually about connecting decision makers and researchers so that researchers understand what it is that decision makers, what the information they need to know, and that policy makers understand what's possible in terms of filling the knowledge gaps that they have, and then putting in place all the mechanisms for the transfer of that knowledge. And as I said, I think a sleeper that is really a surprising responsibility for municipalities is this issue of those people at the very end of that curve that I showed you who require long-term care. How do we do that? How do we provide it in a sustainable way? At the moment, in many countries I visit, I'm told, oh, here it's different. Families look after older people. What that means is women, and it means a woman who can't go to work or a girl who can't go to school. And it's also a delusion to think that it's real. When we worked with one of Alex's colleagues, Isabella Abodarin in Nairobi, what she found is 25% of older people in Africa don't have a family. So who's looking after them? And then of the others, a significant proportion aren't receiving care at all from their family. There's been a split between the generations. And so we have to think, how can we do this better, particularly as we're going to have a bigger and bigger proportion of older people. And I think this idea of the community and how we can foster community development to be able to provide some of that service is a really useful one. And then finally, and my final point, is going back to the very first part of our Global Strategy and Action Plan, around commitment and around reframing the way we think about older age and about older people. Because ageism is one of the most pervasive and destructing prejudices that remains in our society. In many ways, it's even worse than racism and sexism in that it's still acceptable. It's still acceptable to have jokes about older people, to talk about an elder moment, or to imply that, a doddery older person in some sort of negative sense in a joke. We think that's funny. It's not. It's a form of discrimination, and we need to start overcoming it. We need to overcome the institutional discrimination, which we see in issues like mandatory retirement ages. We need to change the way we all think about what it is to become old, what is the role of an older person. And one of the really sad things is that as society has those ways of casting an older person, the older person can then internalise them. And for example, I myself, we have a mandatory retirement age at WHO, and I'm finding in my own mind I'm having to adapt to this institutional form of discrimination, and it changes the way I think about my age. I never before would have thought, oh, well, maybe it's time to take it easy. I would have just kept working. But because that sort of way of thinking has been imposed on me and I've then internalised it, it changes the way I act. It changes the way that researchers think about the issue of ageing. It changes the questions you ask. Instead of looking, how do we foster people's functional ability, we start thinking in much more negative ways. And it changes the way policymakers think about the issue, which takes me right back to the very beginning, because the problem, if we just talk about demographics, is we see this tsunami of older people. You don't see the incredible human resource and potential that's part of that ageing population. You don't seize the opportunity to draw on them and to help build a cohesive society. And instead, we look, how do we cut costs? It's much better to think, how can we invest? How can we invest in the most effective way? And what's going to be the return we can get in terms of that social resource? So, thank you.
Thank you, John. Of course, I have two questions for you to be thinking of at the end. Using the INUH DSS data that Alex referred to, if we look at that, we see that the emphasis is largely on youth and children and women. How do you work with policymakers in such countries to get them to focus on aging and the life course? And the other question is, how can ISUH help engage thought leaders and create action around aging and the life course in LMICs? So please be thinking of that for the end. Thank you. Our next presenter is Dr. Reddy, Srinath Reddy. There you are.
Good morning. Clearly, to an elite audience of urban health aficionados consisting of administrators, academics, and advocates such as this particular figure is not unfamiliar. It's quite familiar. However, to set the context, we must recognize that the pace of urbanization has been indeed extraordinary in the recent decades, propelling the low and middle income countries in particular into a much larger sphere of urban growth. In 1950, the segment of the global urban population was 30%. It grew to 54% by 2014, and it will grow to 68% by 2050. But what has happened is that recently we have seen much larger population growth, much more accelerated in Africa and Asia. Between 2014 and 2050, we will find that the urban segment of the African population would have grown from 40% to 56%, and in Asia from 48% to 64%. Between 2014 and 2050, we would have added 2.5 billion extra people in the urban population, and 90% of them would be in Africa and Asia. And much of this growth would happen in small and mid-sized towns, with 60% of them being actually in less than 1 million population size. So we must recognize that the set menus of steady urbanization that have been applicable in high-income countries are not necessarily relevant to the dynamics of transition that are taking place in low and middle-income countries, which indeed will account for the largest segment of urban population. So when we look at the demographic trends, and I'm only going to summarize some of these determinants, we are seeing a growing global population, particularly in the low and middle-income countries, a rapid rate of urbanization, particularly manifest in the low and middle-income countries, rising numbers of the elderly and very elderly, as has been already stated, but there is also a youth bulge in low-income countries and lower middle-income countries, which needs to be contended with. Otherwise, urban health will be neglectful of the need of this large, younger population. We also are witnessing migration of many tribes, inter-country, intercity, rural-urban, which could be permanent, seasonal, or transient. We are also seeing migration triggered by conflict and propelled by climate change. In terms of epidemiological trends, we are recognizing the rising burdens of non-communicable diseases, especially problematic with the reversal of the social gradient from the high-income groups to the low-income groups, including the slums in low and middle-income countries. Mental illness and substance abuse pose challenges. Comorbidities of chronic conditions will coexist and will cause issues for chronic care in terms of complexity. HIV still remains a threat, and particularly in urban slum and low-income populations. Vector-borne diseases are still on the rise, including several zoonoses, and we are seeing dengue, chikungunya, and urban malaria as important threats. Road traffic injuries are rising quite rapidly, except in the very high-income countries. Overweight and obesity present the new battle of the bulge. And in terms of air pollution-related health effects, we have already had considerable reference to that today. Natural disasters and other climate-related effects will also pose challenges, and all of these will occur even as progress in the Millennium Development Goals, especially on maternal and child health, remain tardy among the poor, including and especially the urban poor. In terms of sociological trends, we see a huge specter of youth unemployment leading to alienation and social conflict, economic inequality and insecurity resulting in political hypernationalism, leading to xenophobia, which, while it might not figure in the ICD classification of diseases, is certainly a social pathology which will affect the health of the population. We see urban crime rising, gender violence quite manifest in many forms, and with the advent of technology and the social media, we see the young connected only to be disconnected, trapped by technology but lost in the crowd. And the response cannot be by merely passively cataloging the catastrophe with increasing precision of the damages that's being done, but by telescoping the transition and reshaping the dynamics of transition so that we can actually create the templates for a health-promoting, equitable, and sustainable model of urban development. And how do we do that? We need to reshape the transitions by addressing some of these determinants. And let's look at health promotion, where we need a life course approach to health promotion instead of a segmented approach that has been given to us by the Millennium Development Goals, but fortunately corrected in the Sustainable Development Goals, which talk about health for all at all ages. But there needs to be a particular emphasis on child nutrition, adolescent health, and active and healthy aging. We need to empower communities and engage technology to reduce the information asymmetry and to fast-track health literacy and to enable health action at community, family, and individual levels, while at the same time recognizing that policy levers are absolutely vital to create an enabling environment which can enable people to make healthy choices and maintain them over a life course. And therefore, we need to influence the commercial determinants of health apart from the social determinants of health through appropriate policies. In terms of the social and environmental determinants of health, clearly this conference is going to be addressing all of these segmentally in various sessions. But when we look at the composite of water security, energy security, sanitation, housing, employment, built environment, urban transport, population control, all of them are so critical to determine the health of the population, especially of the urban population. And here we need to enhance the role as well as ensure the accountability of mayors and municipal bodies, which is not always easy in the relatively concentrated power structures of low and middle income countries where federal and state governments seldom cede adequate independence and autonomy to local authorities. In terms of health care, we do need to promote personal care, not personalized care, but personal care, which is technology-enabled, to expand the role of non-physician healthcare providers, particularly those who can be technology-enabled, to provide a variety of services, including elderly care, as well as mental health counseling, increase the use of ambulatory and domiciliary care, strengthen urban primary care, and also ensure that there is a network of providers to efficiently link primary, secondary, and tertiary care. Primary care has to be the fundamental basis of an equitable health system. And provide rapid response emergency health services and recognize and regulate medical tourism. We do need to look at innovations and experiences across countries. For example, Portugal itself has a remarkable success in reducing drug addiction by decriminalizing and providing supportive services. So these are the ways in which we need a much more sensitive and sensible healthcare system. But universal health coverage has emerged from the SDGs in terms of Target 3.8 as the major platform on which we can actually reconstruct our health system and connect it better with the social determinants of health. We need to design and deliver evidence-informed, context-relevant models of universal health coverage for providing effective, accessible, and equitable health services without financial hardship. And this, of course, will not happen overnight, so we need to practice progressive universalization with expanding service packages over time, but with particular attention to the needs of the poor and the vulnerable sections. We need to steadily increase resources, both financial and human, to deliver these entitlements which have been promised under UHC. And that needs capacity building. But we also need to ensure portability across the country to cover the migrants invariably between cities, between rural to urban areas, and to ensure that everybody has that access irrespective of where they migrate to. Quite often, universal health coverage is sold off as health insurance, often private insurance, or at best as health financing. We need to look at health assurance as three concentric circles. In the innermost circle has health financing, which has to be predominantly tax-based, supplemented by social insurance or other insurance. But to deliver the entitlements that the health financing promises, we need a competent health system with adequate health workforce, infrastructure, appropriate governance, health management information systems, access to drugs, vaccines, and technologies, and community engagement. But in order to provide health in all of its dimensions, we need the third circle, where we need the social determinants of health to be addressed, either at the broader societal level through water, sanitation, food systems, physical environment, and social stability. At the same time, personal factors which are also socially influenced, education, occupation, income, gender, and social support networks. Only when we add the health system element to financial protection will we get universal health coverage. And only when we add social determinants of health to the universal health coverage will we get population health assurance. And this is the message that has to go to policymakers, including those who are shaping urban health. But let me look at how these intersect in a specific area which is not usually dealt with in the context of urban health, that is urban food systems. I'm not talking about urban or peri-urban agriculture here, but I'm talking instead of the increased demand for food products, the increased diversity of food products, food markets, and food cultures, as well as the increased disparities in food and nutrition security that exist in urban environments. Just to give a broad sweep of some of these, urban food systems are more complex and dynamic than their rural counterparts. The average income levels, education levels, and access to healthcare services are more, and therefore there is a greater demand for choice and diversity in food products and stable flows of preferred, desirable foods, and a variety of retail outlets in which to secure access to foods. Competition among suppliers and retail outlets for position in urban supply chains lead to lower food prices. Again, urban diets differ from rural areas because the pace of change is much faster in urban areas compared to rural settings. The scale of social protection and purchasing power policies and programs reaching the urban consumers dwarfs that reaches the rural poor. There is also a high density of social media networks, commercial networks, and information flows in urban areas, which influences food choices. And there's a diversity of population groups in the cities, much more than in rural areas. But there are also environmental issues, example, overcrowding, poor water and sanitation, pollution, open sewerage, and contamination. Consumer purchasing power in urban environments often dictates and determines policies, and urban elites usually have the greatest influence. The high level of disposable income of many urban residents make them attractive targets for mass media and marketing. However, as Alex has pointed out, there are increasing numbers of poor in the cities, and they are sandwiched between policies for the urban elite and for the rural development. And low and irregular incomes are the primary cause of food insecurity and inadequate diets for these. So even as we must reshape our food systems and food policies in urban areas to protect some of the more affluent from the diseases of maladapted modernity, we need to extend the protection to the low-income groups to prevent malnutrition of all types. In terms of food safety, urban supply chains originate in polluted urban areas where there is a lack of traceability and accountability measures for food safety and quality. Growing demand for fruit and vegetables is met with a production response involving irrigation from contaminated water sources, and that again can be problematic. The poorest urban residents, who often depend upon street foods from informal markets, are at an increased risk of acquiring food that poses food safety hazards due to the absence of regulatory inspection and enforcement. And the governance of food systems certainly demands that policymakers at the city scale need to play a much more decisive and proactive role in addressing future challenges, with leaders across the private and public sectors working together. And policy and political changes need to respond to the highly differentiated urban population. But they also need to look at formal and informal markets both, and the power structures that govern the food systems. So the policy recommendations, for example, for urban food systems would be to rebalance and refocus efforts to make high-quality diets and nutrition a policy priority for urban populations as well as rural. Local level leadership needed for better diets and nutrition, certainly, particularly with mayors and municipal bodies playing a bigger role. To capitalize on the diverse opportunities right across the urban food systems, and to address environmental concerns while designing the food systems, and to respond to the needs of different urban population groups, not only in terms of cultural diversity, but also in terms of income diversity. And cities and municipalities should share experiences and information on improving diets and nutrition in their populations. So we recognize that all of these determinants have and intersect and influence each other. But by recognizing these as very important interdependent factors, urban health provides an opportunity to create new models of a people-centered policy palette, a community-centered public health system, and a patient or person-centered healthcare system. Finally, sustainable development is driven by many factors, especially in the urban area. So we are looking at social determinants of health, health services, citizen and commuter safety, food systems, the commercial determinants of health and nutrition. We are looking at community engagement, local governance and leadership, infrastructure and environment. But all of these must indeed actually be coordinated and catalyzed by a convergence platform constructed by urban health. Urban health can indeed be at the heart of sustainable urban development by providing this kind of a pacemaker mechanism and also acting as the conscience keeper of our sustainable development strategy. Thank you very much.
Thank you. Thank you, Srinath. And I have 2 questions for you to follow up at the end, and I'll give them to you. But now we go to our final presenter for the session, Dr. Richard Wilkinson. Richard?
Thank you.
I almost don't want to sit anymore.
I'm going to say, at the age of 74, I feel far too tired to talk to you. I think we should all go and have lunch. I'm going to... what we've been hearing this morning, our ability to achieve the objectives that our previous speakers have talked about. I'm panting, I'm still out of breath from that exercise. Is dependent very much, it's powerfully affected by how equal or unequal societies are. It affects the whole political and social structure of our societies. I want to talk about the ways in which the scale of income and wealth differences in our society affect the health and social functioning of those societies. In a way, what I have to say is extraordinarily simple. It's as simple as that if you have bigger income differences in a society, you have more of a whole range of social problems. I found that diagram on Google Images, and I felt, my goodness, somebody's understood. I'm going to be saying what's on that graph over and over again with different problems on the vertical axis. The data we use, it's now quite out of date. Portugal, fortunately, has improved its position quite dramatically, but you see, which is the, no, sorry. Portugal on the right here, the income differences are not as unequal as they were. They've improved their position relative to other countries. But the measure we use, just because it was easy for people to understand, is how much richer are the top 20% in each country than the bottom 20%. How big is that gap? And you see in the more equal of the rich developed countries, Japan, Finland, Norway, Sweden, the top 20% is 3.5 or 4 times as rich as the bottom 20%. But in the more unequal countries, UK, Portugal, USA, Singapore, the gap is twice as big. And that allows us to start looking at the effects of bigger income differences. Although I'm going to talk about these rich developed countries, the picture looks very similar when you look at developing countries. The important difference is in developing countries, in poorer societies, earlier in the process of economic growth, you also have to take into account the effects of economic growth. In the rich countries I'm showing you here, the problems that I'm showing you are not strongly influenced any longer by the scale of economic growth. I'm just going to summarize a little bit of what was in our spirit level book. We took simply a whole range of internationally available measures of health and social performance, life expectancy in each country, children's maths and literacy scores in the PISA data from OECD, infant mortality rates, homicide rates, proportion of the population in prison, homicide rates, teenage births, trust, how much people feel they can trust others, which is closely related also to how much people feel they can trust governments and other institutions that affect ability of policy and whether policy deals with the sort of problems we were talking about. Mental illness, WHO figures including drug and alcohol addiction, and some figures on social mobility. And you see them there all in one index, related there to the measure of income inequality I've just shown you in the rainbow stripes. And you see the more unequal countries, USA, Portugal, UK, doing worse on all those things than the more equal ones, Norway, Sweden, Japan on the left-hand end. The same thing is true of measures of child well-being. We were a bit worried that people would say that that previous graph, we'd just chosen problems to suit our argument. So we also looked at the Unicef Index of Child Well-being, which has about 40 different components. So children's immunization rates on it, whether children feel they can talk to their parents, whether there's bullying in schools, all sorts of, almost every outcome measurement they can find internationally went into the UNICEF Index of Child Well-being. And you see it's much lower. Standards of child well-being much lower in more unequal countries. We were also able to look at changes in child well-being on the UNICEF index over a period of time, and you see that, of course, as the societies which became more rapidly unequal have worse child health performance. A few examples of how closely correlated the components of that first index I showed you. Imprisonment, it's a log scale up the side, but it's an extraordinarily close relationship. And the differences related to inequality are absolutely huge. You find similarly large differences on some of the studies of homicide and inequality, teenage birth rates and inequality, smaller differences in infant mortality or mental health, but always differences of sort of between twofold and tenfold in the scale of the additional problems in more unequal societies. This is a measure of social mobility. It's important because I think many people believe that these inequalities of income that have grown so much over the last generation are justified if people can find the right level in society. The idea that if you work hard, you move up, and if you don't, you move down, and it's all fair. But actually what the data shows is that social mobility is lower in more unequal societies. The measure of social mobility, I'm afraid it's confined to fathers and sons. It's intergenerational income mobility. It's really asking, do rich fathers have rich sons and poor fathers have poor sons? Or doesn't fathers' income matter very much? And it matters much more in more unequal societies. You know, if we want to improve equal opportunities for children, move closer to that goal, probably the most important thing we can do is reduce the scale of income differences in our societies and between their parents. I want to show you now, as I have rather little time, give you a little sort of nutshell picture of what inequality does to the scale of to the quality of social relationships between us. My ears are having to carry hearing aids, glasses, and microphone. I think I've got that back on. Yes. Here you see a measure of civic participation. It's how much people are involved in local activities, voluntary associations, some of the sort of measures that, what's his name, Robert, Bowling Alone, I'm sure you know who I mean, what's his name? Anyway, lower levels of civic participation, lower levels of involvement in community groups, voluntary associations, in the more unequal societies on the right. If you look at measures of trust, a similar picture. This is from the World Values Survey. The proportion of people who feel that they can trust others, who agree that most people can be trusted, higher in more equal societies. On the more unequal end, 15 or 20% of the population feel they can trust others. In the more equal societies, it rises to 60 or 65%. There are also studies now that show that people in more equal societies are more willing to help each other, to help the elderly, to help disabled people, and so on. So you move from societies with a good deal of reciprocity, strong community life, and so on, to societies with increasing levels of violence. This is one of the most well-studied relationships. People have been publishing papers on the relationship between measures such as homicide and inequality since the 1970s. This comes from Daly and Wilson. The red dots are American states, the blue triangles, Canadian provinces. I may say, if you control for gun ownership, you find that the relationship is marginally closer. This is not driven by gun laws and so on. They very slightly hide the relationship. But the scale of differences is just enormous. At the bottom there, the bottom left, you've got about 15 homicides per million people, rising to 150. One of the criticisms that was leveled against Daly and Wilson when they produced this was that it's not inequality, it's not income inequality that's driving it, it's the proportion of the ethnic mix in each society. You know, many Americans think all the violence and homicide takes place in the black population, and that's what's driving it. So to deal with that criticism, they looked just at homicides committed by white people and measured income inequality just amongst white people. The relationship is almost exactly the same. This isn't a matter of ethnicity, it isn't a matter of gun law. And as I say, with increasing levels of inequality, you move from those societies with a good deal of reciprocity, community life and so on, trust, to the breakdown of community life, the breakdown of trust, increasing violence. And if you look at the really much more unequal societies than we had in our data, places like Mexico, I took this picture when we were giving lectures in Mexico. You find people afraid of other people. They're barricading their houses. There's fences around the outside with razor wire along the top, bars on the windows and doors. And South Africa, that has huge inequality for quite different reasons, exactly the same thing. House after house with these enormous security systems, defense, and so on. And this notice, I'm sorry, it's a blurred picture, says armed response. If you're caught climbing in, you may get shot. And if you don't get shot, there's some big dogs you can just about make out in the background there that'll probably eat you. And the way inequality transforms the quality of social relationships in a society is crucially important to the way the whole society functions, not just these outcomes, but also what governments want to do, what people see as the role of government, what governments understand themselves as doing, whether they're simply a privileged elite who look after themselves, or a society where they have more interest in the well-being of the population at large. Another bit of data that shows just the same picture, that movement from community life and reciprocity in more equal societies to the levels of violence and social breakdown in more unequal societies, comes from Bowles and Jayadeh, two American economists. They looked at international data as here, but also data for the American states, showing that the proportion of the population involved in what they called guard labor, that means people in security occupations, security staff, police, prison officers, all sorts of roles like that, who we use to defend ourselves from each other, increases with inequality. And so you see, they've shown while the United States inequality has increased, the proportion of their population involved in guard labor has increased. Quite big differences. In the more equal countries, it's not much more than 50 workers per 10,000 population in so-called guard labor. It rises to almost 4 times that level. So we pay enormously for the damage that inequality causes in lots of different ways. I think it's wrong to think of inequality simply as a new influence on social outcomes. We've always known that the whole range of social problems have social gradients. We know that health is worst in the worst areas. We know that levels of violence tend to be worse lower down the social scale. We know that the educational performance of school children tends to be less good in the poorer areas. It's those problems which become worse in more unequal societies. So what we're learning is more about the picture that we've always recognized about social gradients. And basically all I'm saying is that the problems that we know are sensitive to social status get worse when you increase the social status differences. Extraordinarily simple picture. If you like, what I'm talking about is whether we have social pyramids, which are great steep pyramids like that, or much shallower ones like that. You know, I'm not talking about totally equal societies, they don't exist. I'm talking about how unequal they are. And as I say, not a new factor, but more about the picture of the importance of class and social status that we've always understood. The only surprise is it's not just the poor who are affected by inequality. I've been pointing out how large the scale of differences is in these outcomes, sometimes up to 10-fold more of a problem, because that in itself tells us this is not driven by the poorest 10% or something. And when we can compare people at each level in society, between more and less equal societies, we find the influence of inequality is bigger at the bottom of society, but even some way up. It's the small advantages in living in a more equal society. Just to give you one very simple example, there are other old data from PISA. This is literacy scores of young people. They're classified by how many years of education their parents have had. So on the right, you've got children with well-educated parents. They've had 13, 14, 15 years of education, and the parents have, nearer the top of society. On the left, children of poorly educated parents. And what you're seeing is in the more unequal United States, the social gradient is steeper than it is in the more equal Sweden. There are now lots of studies looking at comparing people at each level in the social hierarchy between more and less equal countries. And, you know, insofar as one can generalize about the effects of inequality, it does look as if the biggest differences are, as you'd expect, amongst the poor, but even amongst the better off, the advantages in being in a more equal society. That is to say that just as the social gradients affect us all, so the changes in inequality affect us all. So if we take any individual here, take someone who lives in a more equal society, on the same income, the same sort of job, the same education, they might live a little bit longer if they were in a more equal society. They might be less likely to become victims of violence. Their children would be less likely to develop long-term major drug problems or become teenage parents. In that sense, we all do better to live in a more equal society. As this is a conference about urban health, I have to say this is not primarily about local inequalities. It's about the scale of the national pyramid, the social class hierarchy in the whole society. Studies which compare cities in different societies, you find that the amount of inequality in different cities in the United States does seem to predict levels of health, but in most societies you find that cities, whether they're a bit richer than others or poorer than others in that society, that's what makes the difference, not the inequality within each city. It's the inequality within the whole society that matters. When looking at reviewing a whole series of papers, we found that the relationships I've been describing crop up most reliably in studies that take nations as their units of observation, or pretty reliably when they take states, regions, or whole cities, but less reliably in studies that make their measures of inequality within small areas. Because a small local neighborhood doesn't have bad health because of the inequality within it. It has bad health because it's deprived in relation to the rest of society. It's that inequality that matters when you're looking at the local level. Now, I just want to give you, add to what I've said, a picture of the, if you like, the mental or psychological effects of inequality. A study that's come out, when was this? A few years ago, 2 or 3 years ago, shows levels of status anxiety across the different deciles of the income distribution in more and less equal societies. So on the horizontal axis, you have the poorest tenth of the population over on the left, the richest tenth of the population on the right. And the most unequal societies have high levels of status anxiety, people more concerned with status issues across all income levels than people in more equal societies, the bottom line. You know, you can see what that's about. If you're living in a society where some people are seen as hugely important, the way we used to regard the bankers and CEOs as brilliant and deserving their money before the financial crash, and people at the bottom as almost worthless. It emphasizes that way of seeing society, that dimension in our social judgments of each other. And we all become more worried about how we are seen and judged. Those status anxieties, social anxieties increase. And there seem to be two responses to that. You can either become, sorry, before I get onto that, I should say, those sorts of anxieties about how you're seen and judged have been shown in a meta-analysis of over 200 studies, are triggered particularly well, in experiments in which people are given different stressful tasks to do while having their stress hormones measured. It became clear that the things that most reliably push up our levels of stress hormones are not simply doing arithmetic problems or having nasty noises or having to write about unpleasant experiments. The things that involve those social evaluative threats, our worries about how we're seen and judged, those status issues, those status anxieties, we're particularly vulnerable to. Sorry, I've got these in different order from what I thought. Yeah, and pointing out the mechanisms behind the processes I'm describing, Sherry Johnson and a group of psychologists looked at what they call the dominance behavioral system. It's an area of the brain that it can be identified not only in humans but animal species as well, which deals with issues to do with status ranking. They went through a vast literature on personality disorders and mental health, mental illnesses, and found that these issues of dominance and subordination, these issues of inequality, these worries about how we're seen and judged, feed into a whole range of mental illnesses. Anxiety and depression related to subordination, to the submissiveness and the desire to avoid subordination. Mania and narcissistic traits are related to inflated self-perceptions of power. Externalizing disorders, mania proneness, narcissistic traits are related to heightened dominance motivation and behavior. What Sherry Johnson and her colleagues didn't know when they wrote that paper, reviewing a vast range of psychological research literature, was that societies are different. They have different degrees of hierarchy. She thought all societies were fairly similar. We all have class differences, we all have a social pyramid. She didn't realize how that differs from one society to another. And I got in touch and pointed out that there were papers that indeed showed that depression was more common in more unequal societies. There are now 2 or 3 papers showing that same pattern. You become overcome by self-doubts, by low self-esteem and so on. You start to find social interaction stressful. You withdraw from social contact. It's all rather an ordeal. But there's also the opposite reaction. You know, if you're worried about how you're seen and judged, instead of being overcome by self-doubt, you can talk yourself up. You can find ways of bringing into the conversation your achievements and abilities and so on, signs of your success. And in this study, carried out by an international team of psychologists, they looked at what they call self-enhancement in relation to inequality. So they were asking people in each country, how do you judge yourself in relation to your national average? Do you think you're more intelligent than most people in your country? Do you think you're more attractive? Do you think you're more generous? And they got people to rate themselves on those scales. You probably heard that how you're familiar with the joke that 90% of drivers think they're better drivers than average. It's the same sort of pattern, and so in more unequal countries, people rate themselves more highly. It's that kind of self-advertisement. Modesty disappears. You flaunt your abilities and achievements as the opposite response to that social evaluative threat. as the self-doubt, depression, and withdrawal from social life. The other way, of course, we express status is consumerism. And now there are studies showing that in more unequal areas, you spend a higher proportion of your income on status goods, on a flash car, whatever it is. And indeed, I think that's probably one of the important things driving this relationship between inequality and debt. With more inequality, the pressure to consume, if you like, increases, and so people borrow more. I should say just a few remarks about what's driven the big increase in income differences in many, many countries. It's predominantly the rich running away from the rest of the population. This is CEOs' pay in the biggest 350 American companies, and it's how much more they're getting than the average production worker. And in around 1980, the differential was about 1 to 30 or 1 to 40. CEOs were getting 30, 40 times as much as the average production worker. But by the beginning of this century, they were getting 200 or 300 times as much. And that pattern is quite widespread. This is the long-term change in inequality from 1930 to 2015 in a number of illustrative countries. High inequalities until sometime in the 1930s when it started to come down. It goes on declining until around about 1980, and then you get the modern rise of inequality. And interestingly, this seems to be, if you like, a reflection of first the strengthening and then the weakening of the whole social democratic movement, the fear of communism, the strength of the labor movement. And indeed, if you put on that graph the proportion of the population in trade unions, you find that it's an inverse of what the inequality picture is. So that top line, the red line, is the share of all income going to the richest 10% of the population. And the bottom blue line is the proportion of the labor force in trade unions. I don't think that it's simply that trade unions do wonderful things for the wages of their members. I think trade unions help their members. But it's probably more important that trade unions are an indication of the strength of the, if you like, the alternative voice in society. The strength of the population who believe that there's another way society can work, who have a different interpretation of these things. And of course, as that collapsed, it gave way to neoliberalism and the rise of inequality from then on. So I just finish. I think that we're not going to be able to recreate a labor movement in quite the same way as we used to have, at least in countries where the service sector with small employers is so much more important than it used to be. But I do think that we should be moving towards forms of economic democracy. About half the member countries of the European Union have some provision for employee representation on company boards. It's token representation in some countries. It's stronger in others, like Germany, for instance. But I think we must have legislative provisions for that kind of thing, and it must be strengthened over time. So moving towards a society where labor is fully represented on company boards. I think we also need incentives to the growth of more fundamentally democratic institutions like cooperatives and employee-owned firms. And the data coming out of places even like the Harvard Business School suggests the performance of more democratic companies is pretty good, better particularly in things like productivity, than conventionally run companies. So I think that should be our objective in terms of the long-term transformation of our society, to overcome these problems of inequality, to get governments more able to respond to the kind of research we were being shown earlier in this session. So thank you.
So thank you, Professor Wilkinson. I'd like the panelists to respond each to the two questions, and then we will go into quick questions from the audience. I know we're running over, and many of you have to go off to other meetings. Alex, would you like to? Yes.
Sure, thanks. So I have two questions. One is how the NUHDSS, the Nairobi Urban Health and Demographic Surveillance System data, they are striking, and whether we have used this data and our research to help inform health programming and policies in Kenya. Yes, we have. And actually last year, we did an external review of what we call policy impact retrospective, where we looked at where have we really been effective in informing policies. And the work from the urban health surveillance system was top of the list. And what we did learn from that is that in the areas where we have had sustained engagement, we've actually been able to have more successful impact on policies. And it's not just in health, it's in education. For the government creating a division for non-formal education to respond to the fact that 60% of the children in the slums do not go to the public school that's supposed to be free. On health, we've seen the local government, Nairobi City Council, setting up centers, like 10 centers, where people can walk in and get their blood pressure and do blood works to look at diabetes and things like that, because we're able to show that 80% of the people who are hypertensive in the slums have never been tested, and they were unaware of their status. We've seen other places where the government has put in place mobile clinic to respond to the fact that many slum populations are not able to access health care. You have in the places where we work, they had put in a government policy to provide vouchers for women to go to the health facility when they are in labor. But if you're in labor at 2 o'clock in the morning, where do you go to? So through some initiatives that we've done to upgrade the private facilities in the slums to provide basic emergency obstetric care, it has completely reduced and almost eliminated home deliveries, which were at 52% before. Mm-hmm. So now the government is looking at some of those data and evidence and now coming into with new programs to bring mobile clinics through containers and all that to slum communities, not just in Kenya, but in Mombasa and Kisumu and other urban centers. So we've seen huge response and reaction policy-wise. The second question was what ICUH can do to highlight the impacts and engage global actors in dialogue and action. Like the conference we're organizing in Bellagio in November, we would like to invite somebody from ISUH, International Society for Urban Health, to be a key stakeholder in those conversations with national governments, with UN agencies, with development partners, to see how do you really create for example, a cities group on slum statistics and begin to create this dialogue and enforce it. So I think there's a lot that could be done here. And I also do believe that when we take the approach that our urban health focus goes beyond diseases to all the other social determinants and environmental determinants of health within the urban context, I think we will be at the forefront of driving this discourse and engaging in the right type of action that can improve health in the urban areas.
Thank you. John?
Yeah,
briefly, if you could.
You asked about the data such as Alex collected. How do we make that more relevant to all populations? And I think the first thing is we need to collect it at all ages. And we often don't. For example, WHO recommends for our STEP survey of NCD risk factors that you stop collecting it at 65. We need to continue to collect it across the right life course. Then we need to disaggregate it. And if you see data which says people 60 plus, it's rubbish data. because it's aggregating that incredible diversity I spoke to you about before. And if we have to look at things through the lens of chronological age, we should be disaggregating, continuing to disaggregate, for example, by 10-year intervals, so 60 to 70, 70 to 80, 80 onwards.
Excellent.
That's number one. How can ISUH help? Well, I think understanding that a significant proportion of urban populations are going to be older, and understanding that these are questions we have to ask. How do we enable their abilities so they can do the things that they value?
Excellent, thank you. I apologize for rushing everyone. Srinath, you're next.
Well, you asked me how to reshape transitions, especially in terms of food systems.
It's pretty broad, yes.
And also, particularly how to engage national and subnational policymakers. And the second question that you asked me was, how can ISUH help? I think both these are interlinked. Firstly, I think we need to steer the mindset and policy framework of national and subnational policymakers from food security to nutrition security, from adequacy of calories based on staples to adequacy and affordability of nutrients based on diversity of diets. And once we reset that, then we reshape agriculture and food systems policies towards delivering that to everybody on an equitable basis. So that is where we need to actually steer the conversation now. Clearly, what we need to do is to also recognize that there are market forces and try and find out how best we can mold the markets in order to be better aligned to public health and nutrition concerns, and use a variety of instruments, right from regulation and consumer education to pointing out the health dividend of healthier products to the industry. But definitely we need to move our policy in that direction. Now, in terms of how ISUH can help, policymakers do recognize the complexity of systems like these, but dislike lack of clarity that comes from confusing or conflicting recommendations. Where ISUH can help is to provide very clear-cut recommendations based on cogent arguments, but also help in coalition building to advance those arguments through appropriate advocacy, particularly to countervail the influences of some of the commercial lobbies. And there is a global panel on agriculture and food systems, which is an independent panel, which is now looking at the dynamics of how the whole idea of global nutrition security should be addressed. And they're also looking at urban food systems. So you should link up with them and then build up a broader coalitions, draw upon the spirit of the SDGs to build those kind of multi-sectoral coalitions in order to advance policy.
Excellent, thank you. And I'd like to open questions to the audience. Anyone in the audience who had, I see a hand up there for all of the panelists.
Hello, thank you for a great presentation. My name is Anne, I'm from University of São Paulo. And I actually have a question about, to the panel that's such an expert people. Do you have examples of successful policies or interventions that were able at the same time to combine air pollution reduction, mitigate the effects of climate change, and design more inclusive policy that for elderly people that also help them feeling less segregated?
Okay. Accurate policies.
Against air pollution and climate change.
Air pollution and climate change. Any one of you?
I can respond to one of the things we are doing in Nairobi. We've been working with UCL, University College London, and the London School of Hygiene and Tropical Medicine on what we call complex urban systems for sustainability and health. And through that, we've taken air pollution as one of the entry points, particularly for the Kenyan context where there is a government subsidy on kerosene that leads to adulteration of fuel that they use in vehicles that creates even more pollution. And we also have seen the impact for indoor air pollution. So the new government, looking at this data and some of the consultations we've had with the government in Nairobi and in Kisumu, have been able to now adopt a new policy where they banned the smaller buses called matatus from coming into the central business district. And we want to follow that up and see whether that is actually reducing air pollution within that region. and maybe use that for much larger engagement at the national level on how we can deal with the challenges of air pollution in the country. But that's one example of what we've been doing that seems to be having some traction.
Anyone else want to follow up? Yes, Professor Wilkinson.
On climate change, increasingly the environmental movement is recognizing the importance of greater equality to dealing with climate change, moving towards sustainability. Just let me mention a number of ways in which more equal societies do better in environmental terms. One is that consumerism is, because consumerism, so much of consumerism is about status competition, it's driven and made worse by greater inequality, and I showed some graphs relevant to that. But there are also studies that ask CEOs of large companies in different countries about environmental issues. They're more concerned with environmental issues if they live in more equal societies. It looks as if big companies in more unequal societies are more likely to feel that it's not their business, they just have to look after themselves and their companies. That sense of a wider responsibility is stronger in more equal societies. You can see the same thing in figures on recycling, how much people recycle common waste materials. It's higher in more equal societies.
Thank you. Any other questions? There's one hand up here.
Hello, thank you very much for your presentations. My name is Jeling. I'm from the University of Lisbon. I'm a PhD candidate. I was caught by this ageism concept in Mr. Beard's presentation. How do I put this? So it's about discriminating elderly people after they retired, and it's quite related to the mental health, right? I was thinking of how much of this mental health issue of the elderly are caused by ageism, and how much is caused by the fact that there is a major shift of their life in terms of going away from a lifelong professional contribution in their jobs, and how much contribute to that, and what do you think of perhaps of establishing a transition mechanism to help people to go through this period of professional contribution to a new life stage. I mean, that's quite major in their sense that I think it's a cause to many of their physical health problems. Yeah. Thank you.
Absolutely, these transitions are critical. I'd first make the point that ageism isn't just something that older people suffer. It can be something that younger people suffer too, in that they're excluded from a job because they're not perceived as being experienced enough. But I think the issue of retirement is particularly problematic. I don't even know why we talk about retirement as if it is a life stage, because it's a social construct, and in many of the people Alex encounters actually work till the day they die. But for a lot of people in society, when they go through that transition from being overtly seen to have a purpose to not having that broader social purpose, it's very stressful, and it can reinforce feelings of depression, much like Richard was talking about. It's interesting also that if you look at physical activity, you would think that when people retire, they actually would become more physically active. In fact, they become less physically active because they keep the same sort of recreational activity, but they don't have the work activity on top of it. So there's all sorts of implications which come from it. And frankly, I think we just need to rethink the whole of life and think of life as a continuum. And if you feel like working at a certain point or need to work at a certain point, you should be able to. We need to shift from this artificial categorization where people study, work, retire. It's outdated.
Well, thank you very much to our distinguished panel, and thank you all for hanging in there with us, and I hope this has energized you to go forth and continue to think more broadly. I see an indication that there's a hand. Did I miss something? There are two questions. Apologize. We didn't mean to leave you behind. Two questions more, and then I think we have to end after that.
Okay.
Correct? Yes.
This is ASM Mahbubul Alam, representing the Local Government Division, Ministry of Local Government of Bangladesh. My question is to Mr. John Baird. Could you please explain the cross-cutting diagram?
The cross-cutting, what did you say, pardon?
Yeah.
Study.
This is the
Cross-cutting diagram?
Yeah, there was a diagram during his presentation.
Okay, there were two figures. One was looking at physical.
Cookie cutter approach. Cookie cutter approach.
Okay. What I was saying was when we first promoted age-friendly cities, we were very prescriptive in what cities should consider and how they might respond to it. And people ended up with checklists and they go around and just tick the checklist. What we're saying now is it would be much more productive to think in a broader sense about mobility. How do you enable mobility? And it's not just providing transport, it's actually providing disabled access. It's providing safe environments that allow people to continue to be physically active and retain their capacity. So we're saying try not to take that prescriptive approach and think more about the outcomes we're trying to support.
Thank you.
Okay, last question.
Yeah, hi, this is Mukesh from Population Services International India. And there is a presentation, first presentation, there is a very important point, and it says that bring the slums in global reports and, in front of policymakers. So I'm coming from a country where, we are struggling for the slum definition, like listed slum, unlisted slums, authorized slums, unauthorized slums, legal slums, and illegal slums, poverty cluster and all. So as a panel, do you suggest something to, have a global definition of slum and help countries to come up with, that what slum means, so that, globally we are aligned that, okay, so we have that numbers of slums, so that numbers of slum population.
So did you all get that? He's looking
Yeah.
for a global definition of slums.
Okay. I think that's where I often take a position that we should not allow the best to be the enemy of the good. If you look at the definition of urban population in general, it varies considerably across countries. In some countries, a population or a community of 50,000 people is defined urban. In others, you have to be 500,000 population or more. Even despite that variability in the threshold for defining urban, we can still compare the differences between urban and rural within countries and across countries. Part of what we are trying to do at the Bellagio meeting is to actually create a framework that will allow countries within their national framework to be able to identify slums. And we've checked that out in a place like Kenya, where in the 1999 census, they had done a listing of slums and they identified a listing of all the clusters and identified slums. We took 1% sample of those in Nairobi and visited them and could confirm physically that they were slums. And that's how we were able to do a slum survey for all through the city in 2000 and in 2012. So it is possible to do that, but even if there are differences, it's still better than the current definition from the UN Habitat, which is more of a social construct that looks at households that lack access to one of 5 amenities. So you can lack them, but you don't live in a slum geographically. You're still defined by that definition as a slum. And yet, the neighborhood effects that we look for are concentrated within those geographies. So I think it's best, but we need to start somewhere. And that's one of the things we are trying to begin, at least create a framework that countries can look at in trying to map out which clusters in urban areas are defined as slums and document that.
Okay. Anyone else want to respond to that? Okay, we'll go to our very last question. I know you've been eager, so we won't
Thank you.
miss you.
My name is Prince Anyo. I'm from Nigeria. My question is talking about the HIV issue among women. Most information talk about women having challenges or more problems with HIV. Looking at all slum areas and the healthcare system delivery in Nigeria, we have hospitals that opens and closes within specific time. And what we notice is that most of those most people in the slum go to work, because many of them are menial workers, laborers. They go to work at a time when the hospitals are running. What do you think about government setting up policies that will allow clinics to be specifically designed to cater for those men? That might be the reason why we have more information about women and HIV, and we have few about men and HIV in those slum areas. Mr. Alex, please.
Okay. We've done some work looking at ways to respond to health needs of the urban poor. And for the men, one of the things is to identify where are they working, and can you have mobile outreaches to them in those places, because they leave very early in the morning at 5, they come back at 10 p.m. and sometimes you have to actually do their interviews on Sundays or very late in the night, very early in the morning. These are challenges. And the thing is this, I think we have to be context specific in many ways. But one of the things we've already noted is that when you have the health centers and health services within the slum community and they open 24/7, both men and women are more likely to use it when they need it. And so you can't move away from that. But if we use the public system of 8 to 5, honestly, you will miss out. I think when that was the case, less than 20% of all the people that sought care sought it from those health facilities within the slum because of the time differences between their need and the opening hours of the health centers.
Well, thank you. On that note, I'd like to thank our distinguished panel. Thank you all for participating so actively, and a round of applause.